Good morning. Today we are having a word-round discussion on abdominal trauma. Particularly, we discussed about pancreaticoduodenal injuries because we have divided this part into different specific injuries. But I request you to approach this as an abdominal trauma because unless you have some suggestion, you cannot go to that. So we put a scenario, and today will be Dr. Amartya Sengupta, who is a second-year junior resident at IPGM SKM Hospital and now at MR Bangur on DRP. So please show the scenario. Okay, Amartya, read this.
Yes, sir. Good morning, sir, first of all, and good morning to everyone present here. So, a 30-year-old gentleman met with an RTA and presented to the emergency with pain abdomen. How will you proceed?
Okay, so this is a case of rotary accident and you come to emergency and you are the emergency officer there. So how will you proceed? What should be the steps in managing this patient?
Yes, sir. So I will be following the ATLS principles for management of trauma patient. So firstly, I have to start with primary survey, which will involve me taking a quick look at the patient and screening out all the life-threatening injuries. That will involve taking care of the airway with cervical spine protection is the first part, followed by maintenance of breathing and ensuring adequate ventilation, checking for any problems with circulation and correcting any obvious external source of bleeding. In case of exsanguinating hemorrhage with severe circulatory collapse, it is important that circulation be prioritized first prior to going forward with the rest of the parameters. While taking care of circulation, I would go ahead and check for the disability of the patient, namely assessing the GCS of the patient, checking the pupils, and also measuring the blood glucose levels. Following which, I would like to obtain adequate exposure to make sure that the entire body is visible to rule out any obvious overt or occult injuries at any part of the body. And I will also make sure that the environment surrounding is safe for the patient, and also it prevents any obvious evidence of or obvious hypothermia in the patient. So once I have stabilized the patient and ruled out all
now I'll give you a scenario that you have done a good primary survey. He has no head injury. He is having a normal breathing and he's having some amount of hypotension in the form of BP of 90/70, and he's primarily presenting with the pain abdomen. So if you suspect this patient is having an abdominal injury, how should you proceed? As I said, he is conscious, GCS is 15, no head injury. So I am now concerned with the patient having a pain abdomen and likely there is abdominal injury. So how do you approach? Apart from when you go to the secondary survey, it starts with all system examination. But once you go to the specifically abdominal injuries, how do you approach?
Sir, with respect to abdominal injuries, on assessment of the signs and symptoms consistent with the abdominal injury, the first investigation which is usually opted for in case of a blunt trauma patient is FAST or EFAST.
No, don't jump to the investigation. The approach is patient has made the rotary accident.
Yes, sir.
So before you go for investigations,
I would like to resuscitate the patient and stabilize the patient.
Resuscitation, because if 90 is the BP, and so resuscitation goes as a part of primary survey, and the first part to assessment is history. History is important.
Yes, sir.
And what in history is important for a patient who has got abdominal trauma?
Sir, the history,
because history may lead you to some diagnosis. Even on history, and examination can lead to diagnosis before you go for all examinations.
So history would include us taking a look at the mechanism of injury.
How mechanism of injury is important?
So because it depends on
the accident. Yes. So what in mechanism of injury is important? What are the things you try to realize from the attendant or the patient?
So it can be a high velocity impact or a low velocity impact, depending on and also depending whether there is any associated deceleration injury involved in the process, and that will also give us a clue to the extent and the severity of the injuries which might occur in the abdomen. Thereafter, whether it is a blunt or a penetrating kind of injury.
Yes.
So again, our approach to the patient will also vary.
And then particularly you should inquire about specifically. It's a rotary accident. Yes. Was it the driver?
Yes, sir.
If you're the driver who has got a steering wheel impact.
Or a steering wheel impact.
Seat belt.
Yes.
Okay. Or it may be that he was run over by a vehicle. So this history is important. And another important part in history you should mention is whether somebody else has died in the same accident. anyone else died on the spot indicates it's a severe violence.
Yes.
Okay.
Yes.
So these are the important part in the mechanism history, the type of injuries, and then what about other history which may help you in diagnosis of abdominal trauma? Abdomen is a big area.
Yes,
See, abdominal wall, abdominal cavity, retroperitoneum. Okay, so.
So, sir, focus history depending on the symptomatology which the patient is presenting. Just the general signs of features.
Before signs.
Yes, sir, the symptoms. The general symptoms. Which
pain is important.
Pain, abdomen
pain. You have given only one word as pain.
We have to characterize the pain.
Yes, yes.
So depending the site of the pain, the localization of there is radiated to any area or not.
Yes. So whether it's initially when the patient has a trauma impact, the pain may be localized.
Yes.
And if the pain getting generalized, that indicates that might be some bleeding, there might be some perforation or peritonitis. So history of pain is important. What else is important in a patient with abdominal trauma and other symptoms which may come up?
Yes, sir. History of vomiting.
Yes.
And presence of hematemesis.
Yes.
Whether there is any other evidence of upper GI or lower GI bleed is important. And apart from
patient
that,
having a fracture pelvis, the bone infecting into the rectum can cause
hematuria and
rectal
loin pain, swelling.
Yes. Or so keep in mind that history will address these specific symptoms which will help in diagnosis. Whether the patient has passed urine since the onset, whether there is blood at the meatus. Okay, so these are the all symptoms you can make out from the patient. Once you have done this, in history, another important history is there one should not miss, apart from asking about the history of pain and others. What else is important? Particularly if I say the patient history. You don't know the patient. It's an unknown patient.
Yes.
So he might be diabetic. He might be hypertensive. He might be on some drugs like anticoagulants, might be steroids. Okay, so this is very important. So history is incomplete unless you go to this part of the history, past medical history of any comorbid illness or any drug. Because if the patient is anticoagulant, then you have to
increase chances of bleeding. And
bleeding, and then you have to address that anticoagulant drug effect.
Yes.
Okay. Yes. So apart from this, now you are examining the abdomen. Yes. What in examination is important?
So examination starts from inspection, and then we move forward as in the usual way. So inspection, I have to notice whether there is any obvious abdominal distension, any bruising in the abdomen, and the localization of the bruising, and whether there is any imprint of the object with which there
what is the sign called as?
So there is known as scarf sign or a sari sign.
No, that is known as London sign.
Yes,
London sign. London sign is when you have a imprint or what is a pattern bruising. That means suppose he is run over by a vehicle. You can find the impression of the vehicle wheels. Yes. Or patient was wearing a garment, and then because of impact, you can find the button mark on the abdomen. Yes. There is bruising around that. So these are described as pattern bruising. What does it indicate?
It indicates that
indicates it's a severe violence. That when the patient has got imprint of clothing or imprint of vehicle wheel, this is described as pattern bruising or London sign, which indicates the underlying seriousness.
And also
and keep in mind that you have to look for the anteroabdominal wall, lateral abdominal, and the posterior abdominal. So this whole part has to be same. And you look for any bruise around the umbilicus.
Yes, sir.
Any bruise in the flanks. Indicates what?
Indicates any retroperitoneal inflammation or hemorrhage. It's such as in pancreas.
It can be interpreted also.
Yes.
That indicates a interpretation or retroperitoneal hemorrhage. Okay, fine. So inspection. Then
moving on to palpation.
Yes.
Presence of tenderness and rebound tenderness. Rebound tenderness is one of the signs of peritonitis, based on a Bloomberg sign. And also presence of guarding or rigidity.
Yes.
Which can be localized, it can be generalized.
Yes.
And apart from that, there can be evidence of any tender organomegaly which might be present in the patient.
Yes. Why there will be tender organomegaly? Liver may enlarge, spleen may get enlarged, kidney can palpate. Why there is tender hepatomegaly following trauma?
So because there is following trauma, there is pooling of blood and there is thirst patient. So that there is
periorganic
hematoma.
It can be perihepatic, perisplenic, or
or subcapsular hematoma.
Okay. So palpation. Look for tenderness. Look for any tender organomegaly, rigidity, and also try to palpate the lower chest to assess any
fractures, because that can
try to palpate the pelvic area for any evidence of fracture. Okay, look at the urethral meatus. Assess for any bladder fullness. There will be two things. One, bladder may be full. He is not able to pass urine. That is one situation. Or bladder is not full. Possibility may be that there is no urine. Or second possibility is patient is well hydrated. Still bladder is not full. He is not passing urine. It can be.
It might be due to
rupture
of the bladder or the urethral injuries.
No, urethral injury will cause retention, not impalpable bladder.
If it's impalpable, yes, sir. If it's impalpable, then it means there is a rupture of the bladder.
There is a palpable bladder, is not passing urine, trying, then that indicates some urethral injury. If it's bladder is not palpable, one person is in shock. Urine may not be there. Second is if he is revived from the shock and you are not getting the bladder being palpable, he has not passed urine. There is a possibility of a bladder rupture. Okay, fine. Then what in percussion?
Percussion again, sir. One important finding would be in case if there is any obvious perforation peritonitis or Horrocks perforation, there will be obliteration of the liver dullness. Again, from there will be a shift to tympanic node from a dull node. Apart from that, there will be any other obvious evidence of dullness. So that's in case of hematoma or any organized collection in the abdomen. And thereafter, we can move on to auscultation, which can provide us with evidence of any abdominal bruit.
Any role for rectal examination?
Yes, it is important because again, if there is in cases of pelvic fracture, there might be a rectal injury with rectal bleeding, and also rectal examination helps us to check for any obvious collection in the pelvis, which might be appearing as a pelvis.
So you have taken the good history, done a good examination. Is it possible to clinically diagnose pancreatic injury?
Sir, it is very difficult to clinically diagnose with typical clinical signs symptoms. However, we have to take into consideration the history as well as clinical symptoms, which can give us an indication that,
like what in history may make you feel that yes, this might be a pancreatic injury.
Firstly, sir, the location of the impact and the mechanism of trauma. Yes. So any trauma to the upper abdomen with
impact, any impact like steering wheel injury. These are the situations where there is a impact in the upper abdomen. Yes, there is a possible pancreatic injury. Number one. That, as such, it is very difficult to diagnose pancreatic injury on clinical
exam only. Yes, sir.
Okay. Yes. And how else you can suspect that patient might be a pancreatic injury?
Yes, sir. So complaint of pain, which initially was localized to the upper abdomen, then
that may be there in other, but it's not specific to pancreatic injury. Another important lead for thinking about pancreatic injury is the patient is admitted and you have resuscitated the patient.
After 24
patient is doing well for about 20-40 hours, and then there is late deterioration. Okay, late deterioration often indicates some missed injury. Pancreatic injury is one of them. Yes. So if you have a situation like this, that patient was improving and then he started during 24-48 hours, then you should think of because in pancreatic injury, first CT scan may appear normal.
Yes, sir.
So in that case, you need to do a second investigation.
Repeat CT.
Okay. Fine. Now I'm thinking about the situation that you have assessed the abdomen and you have diagnosed that patient has got some intraabdominal injury. And what should be the approach now? What do you do? What is the first thing patient asks for?
Depending on the hemodynamic stability of the patient, if the patient is hemodynamically stable and is not fluids, I would like to follow it up with a contrast and CT scan.
I tell you first.
We would like
you have done a clinical assessment before ultrasound. The answer should be first. First or first.
Yes.
Okay. So the first thing to do in the ward itself is when you do a bedside bedside first. What do you see in first?
So in first we check for VSS4 in fast it's a VSS4 areas, and in first we add the chest bilateral thorax movement. So there is a group we can rule out any obvious pneumothorax and on a previous collision
and hemothorax. Hemothorax also.
Yes, sir. Collection.
So pleural movement, any collection in the lower chest.
Lower chest.
Okay. Yes. Fine. And in the abdominal cavity, what do you assess?
We check firstly we assess the perihepatic area, and we first step is the subdiaphragmatic subxiphoid area to assess for any pericardial tamponade. Then we assess the right upper quadrant, to check for any fluid in the hepatorenal pulse of Morrison, followed by the left upper
It's
quadrant.
looking for only fluid. It's not that you just start assessing the liver or spleen.
We
No.
have just it is just to mention whether there is any free fluid in the
Yes.
abdomen or not.
So
It's just
right upper
quantify it as
quadrant, left
positive or
upper
negative.
quadrant, and the
pelvis.
Fine. So you have done first. There is evidence of some fluid in the pelvis and also in the upper quadrant.
Yes, sir.
What
So
next?
if
What next? And there is some evidence of peritonitis. There is some evidence of peritonitis, and the first revealed there is free fluid.
Yes.
What should be the next investigation? Very simple investigation, not CT.
Sir,
No, DPL is not practiced much now.
Used only if there is
Next
no
is chest
X-ray.
X-ray. Why?
Again, sir, to look for any free gas and diaphragm.
Yes.
To rule out any free gas.
The next is chest X-ray. Because chest X-ray will help you number of ways. The most important is you find free gas on the diaphragm. That indicates that this is a hollow viscous patient. That dictates that patient has to go to the theater.
Yes, sir.
And you can diagnose pancreatic injuries while on exploration.
Yes, sir.
Okay.
Yes, sir.
So the next image should be a chest X-ray. Any rule for abdominal X-ray?
Sir, if there is any, yes, I mean, if there is any signs or symptoms of maybe infection or dilatation, it is important.
There is no question. A chest X-ray abdominal shall be straight order.
Yes.
Because you see, abdominal X-ray cannot give you a definite diagnosis.
Yes. However, it can point
towards. Yes. What in abdominal X-ray may suggest that patient has got a significant abdominal injury?
Sir, if there is any obvious presence of
free gas inside the chest. Free gas has gone in chest. What
there
is
any ground glass opacity?
Yes, ground glass opacity indicates what?
Any fluid in the abdomen?
Fluid or blood
on the abdomen.
Next,
sir, any obvious dilatation in the gut?
No, before that, there are some more important points which should be looked for abdominal X-ray. Swath shadow. Yes, sir. Obliteration of the swath shadow. And also you can see the yes. You can, if there is a peripheral hematoma, you can see the kidney outline is enlarged. Yes, you can look for any retroperitoneal gas. Yes, okay, that is a important finding in duodenal injury. Yes, you can look at the lower ribs, and there is a fracture in the ribs or not. Okay, that can again point. So these are the two simple impressions. You should not forget to say in the abdominal. That is a protocol. We have to continue. And then next, what do you think about saying DPL? So DPL was very popular, but there is no fast kind of fast. But at the moment, I think you should omit saying DPL as part of workup. If the examiner asks you, you can say yes, DPL. Otherwise, DPL should not come as the next investigation. Next investigation is what? The next investigation would be contrast. Yes. Next investigation should be a continuous CT scan. Okay. So now you have done a continuous CT scan, and what in CT scan will suggest that patient has got a pancreatic or duodenal injury. I'm now coming to this our point of discussion. Okay. So on what in CT scan will suggest that what you can see on contrast. Talk of pancreatic injury, talk of duodenal injury, because some signs in the CT will be different. Yes. So in case of pancreatic injury, there will be obvious malperfusion, hyperperfusion of the pancreatic parenchyma, and then we will evidence of peripancreatic fluid collection. Yes. Or hematoma. The first thing is to look for is a hematoma or peripancreatic fluid collection. And next thing again, there can be evidence of, although it is more difficult to see on a CT, but there can be evidence of pancreatic ductal disruption in the form of peripancreatic inflammation and fat stranding. Inflammation, and if there is a transection of obvious transection of the pancreas. And what is the most common site of pancreatic transection? It is the neck of the pancreas. Neck of the pancreas. Why? Because the neck is usually it gets sandwiched between the vertebral column posteriorly and the blunt impact of the pancreatic impact anteriorly. So it is not 100% sensitive, but in some situations you can find there is a transaction. Yes. You see, it's difficult to make out dark disruption in CT scan. Yes, to demonstrate dark disruption, you have to do either MRCP or GRCP. But CT, these are the two important areas where you have a suspicion that there is a peripancreatic fluid collection or hematoma, and you can demonstrate there is a transaction. You see, the hypovascularity in the form of pancreatic necrosis will not come up in the acute setting. Yes, it will come later. Okay, it will come late. How do you suspect duodenal injury in CT?
So again, there is increased thickness of the duodenal wall, which means has to be duodenal hematoma, or there will be evidence of periduodenal air shadow or fluid.
Retroperitoneal gas, and they have given contrast.
And there is, if they are given contrast, there can be evidence of leakage of contrast.
Yes. Extravasation of contrast. Okay, so this patient has got in CT. They are suggested there might be some pancreatic injury.
Yes.
There are some situations where after resuscitation you need to go to the abdomen exploration early. What are the early indications for laparotomy in abdominal trauma? Not thinking of pancreatic or whatever. There are some general indications that you have to do a laparotomy quite early in your line of management.
So that would be in case of hemodynamically unstable patients with non-responding status. Number two would be in case of overt features of peritonitis.
Yes, first think of this. Patient has got precancer diaphragm, suggestive of perforatic peritonitis and hollow viscous perforation. You have to do early laparotomy after resuscitation. Patient has got some solid injury
which is unstable.
Patient cannot be resuscitated. In spite of resuscitation, he is deteriorating.
We have to go for an early laparotomy to control the active bleeding.
Okay. Anything else?
And in case of hemodynamically unstable patients, and in case of whether if it's a penetrating injury, injury, which obviously
penetrating injury where you have features of
peritonitis and evisceration, obviously.
Yes. Okay, fine. So while doing laparotomy, how do you diagnose that patient has got pancreatic injury? You have opened the abdomen for small gut perforation. There is a trauma and there is a small gut perforation. You have addressed that.
We have already performed done the usual steps to place the injury.
Yes.
So in case of pancreatic injuries, there may be evidence of fat saponification in the left side.
That is one.
And there may be retroperitoneal bile staining or any evidence of any obvious peripancreatic collection. Or
how do you assess pancreas? Pancreas is not a visible structure on exploration.
So sir, even on exploration, if we suspect that there is a pancreatic injury, then the pancreas has to be explored.
How?
So first of all, we would like to. There are two aspects to that. First, we have to dissect and lower down the hepatic flexure, and then reach the duodenum and achieve a wide cockroachization of the duodenum, so that we can analyze the duodenum and the pancreas together.
Injuries are more common in the body and renal. In that case,
and we have to open the sac. Open the lesser sac.
First, open the lesser sac.
And
open into the lesser sac.
And then
look at the body. If there is a hematoma, will you explore or not explore?
In the pancreatic injuries, we should explore.
Yes. So if there is a hematoma, you have to, inside the hematoma, go to the pancreatic substance to look for any transaction or laceration.
And also we have to explore the posterior wall of the pancreas as well. That will involve us separating the pancreas from the transverse mesocolon. That is the fourth layer of the you separated that, and then
you continue to set on Fine. So you have now decided that patient has got a pancreatic injury. Okay.
Yes.
What are the steps? Patient has got abdominal injury and there is associated pancreatic injury. What are the steps in doing a good laparotomy? How do you start?
Yes, sir. So laparotomy is approached via midline vertical incision.
Yes.
And thereafter, we have to check upon entry into the abdomen. First thing we have to see whether there is any fluid collection or any hematoma in that. We should be evident.
Hematoma.
Yes. Sir. Then thereafter, we have to deliver the gut out of the abdomen and start with the fourth quadrant packing.
Yes.
From sequentially starting the right upper quadrant and with the left lower quadrant.
So you have put 4 packs.
Yes, sir.
Right upper, right lower, left upper, left lower.
Thereafter,
small gut is out.
Yes, sir.
How do you start exploring now?
I have to perform an entire bowel run.
How?
So I will start from the stomach itself.
Yes.
And ensure I have to check for both pancreas as well as posterior subcutaneous stomach to try opening the recess to rule out any obvious injuries. Yes. Then proceeding further downwards, the duodenum can be mobilized with a wide cockroachization.
Yes.
And then we have to start from the duodenal jejunal flexure, the ligament treats, and then trace the entire small bowel to the ileum, where we will find a fixed area that is the ileocecal junction. Thereafter, we go on tracing along the ascending colon, the transverse colon, and the descending colon. And even we should also try to make an attempt to check the rectum whether there is any obvious collection in the.
Yes. So that is the sequence you should follow. Once you pack the abdomen, even there is a bleeding, that bleeding might stop because of packing, and then do the systematic exploration from stomach up to the large gut, up to the rectum. Then how do you start removing the pack?
So that will be sequential packs from below upwards.
Yes. So remove the lower pack. Okay. And remove the upper pack.
Yes.
So there you can find the bleeding or whatever and then address that case. Okay. What are the important steps in management of pancreatic trauma? Because in pancreatic trauma, you have to grade the trauma.
Yes.
What are the grades?
So, sir, there can be a AST grading, or there can be Lucas grading in case of pancreatic trauma. So, in case of AST grading, we have 5 grades. Grade 1 would involve a minor contusion or laceration to pancreatic without any duct disruption or any minor hematoma. Grade 2 will involve a major contusion or a pancreatic injury without any duct involvement or disruption. Grade 3 involves a ductal disruption involving a distal pancreas with or without a distal transection.
Yeah.
Grade 4 involves a proximal transection to the an injury to the head of the pancreas with involvement of the ampulla. And grade 5 involves a combined duodenal pancreatic injuries and massive pancreatic
aid and revascularization.
Yes, sir.
And duodenal injury?
Duodenal injuries can be again graded into 5 grades. So for grade 1 would be hematoma, which is located to only one part of the duodenum, and the laceration, which is a partial thickness laceration, there's no obvious perforation, through perforation. Thereafter, we have there is no perforation. So there is then we have grade 2, where there is presence of hematomas in more than one side, and there might be a perforation, but it is involving less than 50% of the circumference, irrespective of the site. Then we have grade 3, where we have involvement of 50 to 100% of the circumference in D1, D3, and D4 regions of the duodenum, and 50 to 75% of the circumference in D2. Then we have grade 4, where we have almost 100% of involvement of the circumference in the D2 part of the duodenum, along with injury to the ampulla and the distal part of the common bile duct. And we have grade 5, where we have a combined pancreaticoduodenal injuries with revascularization of the duodenum.
Okay. Now I give you a scenario. This patient has got a probable diagnosis of major pancreatic injury. Patient is hemodynamically unstable.
Yes, sir.
Okay. So you have explored there is no other injury in the other part of the body, but patient has got a grade 5 injury.
Yes, sir.
And patient is not hemodynamically stable.
Yes, sir.
But you need to do the laparotomy because of instability.
Yes, sir.
What would you do?
So my approach would be to
severe
control
surgery. What is damage control surgery?
So damage control surgery is a part of the damage control resuscitation spectrum, where we perform the basic minimal surgery which is needed to
suppose this is a pancreatic injury.
In this case,
what damage control surgery will be involved in this situation? Number 1 is what?
The number 1 is first of all, we have exposed the pancreas completely and we have explored the hematomas. We would need a wide pancreatic drainage in such patients. That is very important, so that we can divert the pancreatic control the bleed, which is
first you control the bleed, and then
prevent
if
the
patient is unstable, there is no question of doing any major surgery.
Yes or no.
Okay, you pack, come out to ICU, and then reassess after 24 to 48 hours. Okay, patient is relatively stable, but not fit enough to proceed with a major surgery of a standard pupils. Yes. What else could be done as damage control?
As damage control, sir, I can
because there is a pancreaticoduodenal transection.
Yes,
there is a major pancreatic head injury. I'm talking of severe injury.
Yes, sir. If the
what else can be damage control?
Sir, a bypass can be a damage control.
Bypass is a very
sir,
damage control may be only resection.
Resection, yes, and
damage control. Second part is only resection, yes, no anastomosis.
No anastomosis.
So whatever is injured, you do a resection part,
and then
keep everything closed,
and we put drains and we come out.
Yes. So this is another damage control component. One damage control, you just control the bleed, control contamination,
and come out.
Drain and come out. Yes. Second is, if possible, you can resect, but don't go for complex reconstruction.
Restitution of continuity is done later.
What should be done for a grade 1 and grade 2 pancreatic trauma? What should be the approach?
Sir, after we have explored the pancreas and ruled out any severe,
you could diagnose grade 1, grade 2 on investigations.
That can be
managed. Some abdominal pain, some amount of rigidity, but there is no overt situation that patient needs urgent laparotomy.
A grade 1 or grade 2 pancreatic injury can be controlled managed conservatively without going for immediate emergency or exploratory operation. However, we need to keep a high level of alert and vigilance.
Even in grade 2 injury, it is difficult to make out whether the patient has got a ductal disruption or not.
Yes.
Okay, if there is a ductal disruption suspected, then there is a question of doing laparotomy. There is a transection in the neck,
yes,
and you explode.
Yes.
What should be your surgical management?
So, ruling out the damage control setting, and the patient is stable right now.
Yes.
Okay. So again, sir, at the neck, so we have to first of all check our relationship of the superior mesenteric vessels with respect to the pancreas. On the left side of the SMA, we have
that one. There is a transection. Usually, it is like your neck transection.
So, sir, what we can do is that we can, if the patient is able to tolerate surgery, we can go for distal pancreaticotomy. And
you have to add, particularly in this situation, it should be a spleen conservation.
Spleen conservation, yes, sir. Without moving the
if the spleen is not injured,
then we should
try to
preserve
do a spleen conservation distal
pancreaticotomy, and then and the proximal stump is closed by doubly ligated duct, and then the parenchyma is closed with horizontal mattress and or even staple.
There is no pancreatic injury. There is duodenal injury.
Again, sir, yes. That would, sir, if it is if a duodenal injury is detected during a laparotomy, incidentally, again it would be better to create the injury. If there is an obvious duodenal hematoma without any obvious concerns for any full thickness perforation, duodenal hematomas should not be unduly explored. However, if there is any history of any high velocity impact or any preoperative investigation suggestive for duodenal perforation with a leak,
then I find there is a 100% circumference duodenum and there is major laceration.
Yes.
What to?
So that would again depend on the site of the duodenum, whether it's in D1 or D2 or D3 or D4. So in case of D1 injuries, if the perforation is small, we can go for primary repair. However, in case of major lacerations, 100% circumference injuries, we can go for dissect that involved area. We can go for a primary anastomosis in cases.
And means what? If you resect the duodenal area and part of the
end-to-end anastomosis, we can be done.
That is what? That is either a Billroth 1 or
Billroth
2 reconstruction.
And also, sir,
so D2 injury,
sir, again, it depends on the site of the injury. If it's in the lateral wall and it is repairable, we can attempt to go for a primary repair. However, if it is involving the ampulla,
what is the problem with primary repair?
There is an increased chance of failure of repair and fistula formation.
So if there is a laceration only the full circumference, then apart from primary closure, what else can be done?
So we can go for attempt for a bypass situation.
Yes.
That is a ruined by duodenal jejunum.
Duodenal, not gastrointestinal. It should be duodenal jejunum. Okay. When there is a complex injury, what is the role for doing a Whipple surgery in this patient?
Sir, first of all, in a complex injury of our grade 5 injury, and in the initial setting, we will not attend for any definitive surgery because that leads to high mortality. We just put in drains, do a damage control surgery, and come out and keep the abdomen open for a deep suppuration. After we have stabilized the patient adequately, after 24 to 48 hours, we might take the patient up for a pancreatic duodectomy. However, even in such cases, the patient might not be even in a position to tolerate the entire surgery in one setting, and we might need to have to consider for a staged reconstruction. So resection in the first setting and then anastomosis in the next setting.
So the decision for Whipple's operation in trauma setting should be taken with caution.
Yes.
Most of the time, patients are unstable, not fit for a Whipple decision because there is very high mortality for it.
Yes.
Okay. What are the complications of pancreatic injury?
So the complications of pancreatic injury would involve pancreatic duct disruption leading to pancreatic. Yes, sir. It can lead to pancreatic ascites, pancreatic fluid effusion. It can lead to pseudocysts of the pancreas and pancreatitis, or it can lead to retroperitoneal hemorrhage and lead to progressive systemic response syndrome and SIS, and ultimately it can culminate in organ failure. And apart from that, it can lead to most important being pancreatic fistula.
Trauma, yes. Complicated pancreatitis should be first of all a hematoma can be contained, yes, or hematoma may be expanding. There is situation where patient may have pancreatitis. If that disruption you are not managed by surgically, there will be formation of pancreatic fistula, which is it will be pseudocysts, it will be pancreatic ascites, or it can be a dural collection. Okay.
Yes. Or it may be pancreatic enteric fistula.
Suppose patient in the post-op period, you have drained the patient. and there is no major laceration, but patient developed pancreatic fistula.
Yes.
How will you diagnose pancreatic fistula in the postoperative period?
So it is defined as any measurable drain output on the postoperative 3 with brain MRS level of more than 3 times a serum MRS level.
So what is the natural course of pancreatic fistula?
Usually, pancreatic fistulas tend to heal spontaneously with adequate conservative management. Again, that depends on the output of the fistula. So in case of conservative management with low output around 200 milliliters per day, we can attempt to provide nutritional support to the patient, enteral, and also supported with parenteral nutrition. And we can add octreotide. A short course of octreotide to 5 days has been shown to increase the rates of and
so management again will depend on the grade of fistula.
Yes.
If it's a
simple
mild fistula, then intermediate grade may be managed conservatively, but severe grade pancreatic fistula may require subsequent surgery in the form of either dissection or a bypass.
Or if there is a pancreatic duct disruption, it is amenable to any endoscopic manipulation, we can go for DSP instead.
Okay, I think it should be enough. Go ahead, Dr. Maiti, and chat begin. Yeah, there is a question saying that if you have done a assessment for the patient, that patient has got a free and diaphragm, should you do a CT scan? Yes. In a trauma setting, because when the patient has got a rotary accident and patient has got a free and diaphragm and patient is otherwise stable, then you can skip doing a CT scan. But in a trauma setting, always it is advisable to have a CT scan done. Yes. Sure. Dr. Maiti?
Professor Sir.
Yes. Yes. Any question?
No, it was extensively discussed. Almost everything was covered.
Okay. We can just go through few slides I prepared. Just go. No. Yes. Okay. So he has answered almost all the questions.
One thing must be remembered, that pancreatic injury, when there is associated injury in the abdomen, particularly the intestine and the kidney, that should be very carefully looked for, because kidney injury is possible, and as well as intestine, we have said.
And another thing I try to emphasize is when you do a laparotomy, you have to export the retroperitoneum if there is expanded hematoma. And there are 3 zones in retroperitoneum. One is zone 1 is medial bottle of kidneys, above diaphragm and below aortic bifurcation. Zone 2 is laterally of retroperitoneum and the paracardic arteries. And zone 3 is the pelvic retroperitoneal area. Next. So we have already discussed that these are the background where you suspect a pancreatic injury or pancreatic injury. Blunt trauma abdomen, fall from height, steering wheel injury, hit by a bicycle or motorcycle handle, direct blow to epigastrium or penetrating perforating injury. What is the difference between penetrating and perforating injury?
Penetrating injury means it is a through and through injury.
Penetrating? No.
Perforating injury means that it has encroached into a body cavity, and it has also gone through and through the cavity. And
simple answer. Penetrating injury, while you have only wound of entry.
Only one side of
yes, and perforating injuries you have 2. Both. Wound of entry and wound of exit. So that is the basic difference between a penetrating perforating injury. Next. And this is the Lucas classification we have discussed. That there is type 1, type 2, type 3, and type 4 combined pancreatic injuries. Next. There is a AST grading for pancreatic injury. He has given the correct description of this. Then AST grading for duodenal injury. And these are important because your management will vary depending on the diagnosis on table. Next. So we have already discussed when to suspect a pancreatic injury. This should be based on high index of suspicion. As I said, if there is impact of the steering wheel or there is a blow in the epigastrium, there is no specific signs, symptoms of pancreatic or duodenal injury. These can blur with other intraabdominal injuries. And majority of these pancreatic injuries are diagnosed during laparotomy. Okay. The pain may start in the epigastrium and then become generalized. And the delayed deterioration. Patient was improving with constant treatment. Again, start treating after 24 to 48 hours. Next. So these are the different investigations that can help in management of a pancreatic injury. Like a serum amylase level, USG, CT scan, which can reveal peripancreatic fluid, hematoma, it can demonstrate transection, retroperitoneal gas, and sometimes initial CT can not give a correct diagnosis. In that case, you need to repeat the CT scan. And if you suspect that pancreatic ductal disruption, there is a role for MRCP and ERCP, even a pancreatic stenting may help. Next. So, on laparotomy, while doing laparotomy for other reasons also, you should try to find out any evidence of pancreatic injury. You have to exclude pancreatic injury by entering lesser sac. You have had saponification, or you may have to consider resection some time further. And as I said, Whipple's is the last part you should consider because there is very high mortality. Next. So these are the different options for management of duodenal injury. If there is a first part duodenal injury, you can either do a closure, primary closure, or resection. D2 injury, you may do a resection, there is a major laceration, or you can do a debridement and a duodenal jejunostomy. D3, D4 are also same, either a closure or resection. Next. Okay, so we have discussed that on damage control surgery is the most important if the patient is hemorrhagically unstable. Next.
The patient has lethal.
Yeah. So pancreatic injury treatment again is same. Grade 1, grade 2 should be conservative. Grade 3, the drug disruption, the neck, it should be a distal pancreatic splenic conserving. Grade 4 is damage control surgery followed by resection. Some patient may be held by ERCP, or in life-threatening situation, you have to consider for Whipple's pancreatic. Next. So these are the indications of non-operative treatment, where you suspect grade 1, grade 2 injuries and stable and no features of peritonitis, and particularly endoscopic injuries. Endoscopic injuries occur in the second part near the ampulla. There is a role for doing conservative treatment in this patient by giving the patient nail orally, Riles tube, and if possible, you keep the patient on fasting for a longer period of time. Next.
So there is also grading for perivegetarian injuries.
So this is a pancreatic fistula I have discussed. Next. And these are the important complications of pancreatic injury. Duodenal fistula, pancreatitis, pancreaticosis, hemorrhage. In some patients who undergo resection or gross pancreatic injury may have subsequent development of pancreatic exogenous insufficiency and diverticulitis. Next. Thank you.
Professor Saha. Hello, Professor Saha.